Yes, students, you are welcome to this lecture. Today we are going to look at menstrual disorders and specifically we are going to look at amenorrhea. So I'm called Kiden Robin. I'm going to take you through this lecture. This is still a continuation of our gynecological topics. So when we talk about amenorrhea refers to absence of menstruation. The types of amenorrhea include physiological amenorrhea. Here, we refer to as periods when the woman is not menstruating, but it is something natural. So we are not worried about it. And this happens before puberty, during pregnancy, during lactation, and in menopause. Then the second type we have pathological amenorrhea. This one is the abnormal one, and this is due to some causes as we shall look ahead as we continue. Then primary amenorrhea refers to delayed menarche. For example, we expect that a girl should go into her periods before 17 years. But when it is more than 17 years, for example, the girl uh, is now 19, 20, and she has not gone into her periods. This is what is known as primary amenorrhea. Then secondary amenorrhea, absence of menstruation for greater than 6 months after normal menarche. If the mother, the girl has gone into her periods, then she stays for a period of greater than 6 months. For example, she goes into like 1 year without seeing her periods, meaning there is a problem. Let's look at primary amenorrhea. What are the causes of primary amenorrhea? We have hormonal factors, for example, pituitary gland malfunction. As we know, in the reproductive system of the woman, the pituitary gland plays a very important role because it produces those hormones that help in maturation of the maturation of the ovum, then release of the ovum, and in this process also there are those hormones that are responsible for development, preparation of the endometrium. So all these, in case these glands that are involved here are affected, then of course menstruation will not take place. Then another cause can be developmental abnormalities like of the vagina, uterus, or ovaries. Let's look at secondary amenorrhea. The common causes are pregnancy, lactation, emotional stress, or lifestyle changes. For example, changes in the kind of type of activities, changes in the feeding habits, and many others. Then we have the pathological types. The pathological types include false amenorrhea, which can be known as cryptomenorrhea, then obstructed menstrual flow, for example, imperforate hymen. Symptoms include abdominal pain, no visible menstruation. Then the treatment can be, the hymen can be incised. This can be done by a gynecologist. He can incise the hymen to create that path so that the menstrual flow can be able to go through. Then the hygiene should also be maintained well. So we still continue with secondary amenorrhea. When we look at secondary amenorrhea, we have looked at the pathological types where we looked at false amenorrhea, and here we said that normally because of obstruction. This means that there is no problem with the physiology of the woman's body, but because the hymen has blocked the way, so the menses cannot be able to pass through. So, what about the true amenorrhea? The true amenorrhea, here there's absence of endometrial cycle due to uterine, ovarian, or pituitary disorders. So, causes of true pathological amenorrhea include uterine disorders. For example, congenital abnormalities, e.g., uterine or vaginal atresia, where there's an abnormality which happened maybe during the development of the woman. Then atrophied endometrium post-radiation or hysterectomy. If the woman goes through radiations, for example, during treatment of cancer, or if she has been done hysterectomy, then the endometrium will, first of all, in the hysterectomy, it will mean that the uterus is already removed out, so she will not be able to menstruate. So, in the post-radiation, means that the endometrium may be affected, and as a result, it atrophies, it shrinks. And once it shrinks, then the bleeding will not be able to take place. Ovarian disorders, here we have gonadal dysgenesis or fibrous streaks replacing ovaries. So this can happen due to, and it leads to these fibrous streaks that can develop and replace the ovaries. Then enlarged ovaries with multiple cysts, for example, Stern-Leventhal syndrome. Then post-oophorectomy, which refers to ovary removal. If the ovaries have already been removed, then the woman will not be able to go to have her menses. Causes of true pathological amenorrhea continued. Pituitary disorders, pituitary infantilism. Here, this refers to delayed growth. This can be corrected by use of growth hormone. Then Sheehan's syndrome. This can happen if the mother bleeds a lot during postpartum period, and it can lead to pituitary pain. The pituitary gland will not be supplied with enough blood and oxygen, and as a result, it can die off. Then nervous disorders, stress-induced hypothalamic suppression of the follicle-stimulating hormone and luteinizing hormone. If the woman is stressed, the stress can end up leading to non-production of the follicle-stimulating hormone or the luteinizing hormone, or they can be produced in low quantity. And we know that these ones are the ones that are responsible for the development and the release of the ovum. And depression, anxiety, anorexia nervosa, or excessive exercise, e.g., marathon runners. This can also lead to disorders that can bring about amenorrhea. Then we look at definitions of key terms that we have used so far. We have dietary causes. The dietary causes, these ones refer to fasting, nutritional deficiencies, or severe weight loss affecting hypothalamic function, so leading to the hypothalamus not to function well. Then the drug-induced here refers to the post-contraceptive amenorrhea, which can happen 3 to 6 months after the person has stopped using the family planning. So the woman can take 3 to 6 months without bleeding in after the use of family planning. Then we have drugs, e.g., phenothiazines, hypotensives, causing hyperprolactinemia, which can lead to amenorrhea. Once the person is using these drugs, the person is likely to develop hyperprolactinemia, then which leads to amenorrhea. Hyperprolactinemia refers to the production of the prolactin hormone in higher quantities. So when it is produced in higher quantities, it will make the body to assume that the woman is breastfeeding, and because of that she will not go into her menstrual periods. And this, in most cases, can lead to production of milk in the woman's breast even when she is not breastfeeding. Systemic diseases can also be one of the causes, and these refer to chronic diseases like TB, severe hyperthyroidism, myxedema, diabetes, and Addison's disease. Management of amenorrhea. Assess overall health. Consider psychological and environmental factors when managing amenorrhea. Look at how the woman is. Is she stressed? What are the other environmental factors around her that may be able to affect her health? Then reassurance and education. For young girls with normal exams, wait until 18 years and provide health education on sexuality. A girl may come when she is 16 years and is complaining of amenorrhea. She has never gone into her menarche. So she can be educated on the normal cycle and the odd cases that can happen, and also she can be reassured and I told you 18 years to make sure that the other examinations can be done. Investigations. Here we have taken differentiated primary and the secondary amenorrhea. The woman's history to find out whether what she's experiencing is primary or secondary amenorrhea. Then assess menstrual disturbances or physical symptoms surrounding the mother. Then examination, pelvic examination, and this one margins should be and to avoid the pain because it can be very painful. Assess secondary sexual characteristics and exclude pregnancy. Someone may complain of amenorrhea when indeed she is pregnant, so this one should also be ruled out. Radiological tests like chest x-ray to rule out tuberculosis, because we have said tuberculosis is one of the pathological causes of secondary amenorrhea. Then skull X-ray to detect pituitary abnormalities, for example, enlarged cellular tachycardia. Then endocrine tests. Here, a 24-hour urine collection can be done for hormone levels. Then blood tests for follicle stimulating hormone and luteinizing hormone and the prolactin. This one refer for high prolactin levels, and if detected, then treatment can be done accordingly. Laparoscopy detect developmental anomalies. For example, in the uterus, ovaries, then the fallopian tubes. So how the structure of the uterus, ovaries, and the fallopian tube is well known. So the laparoscopy, this is where an instrument is inserted into the uterus and moved to the tubes to see whether the development of those organs is normal or abnormal. Dilatation and curettage. Diagnose endometrial tuberculosis or other infections. Then other tests can include ultrasound, CT scans, visual acuity checks. These can all be done to rule out the cause. Medical treatment options. These include clomiphene citrate, or commonly known as clomid. The indication is for ovulation induction in cases where the woman is not ovulating. So the start dose is 50 milligrams per day for 5 days and can be increased to 200 milligrams if needed. Side effects include ovarian hyperstimulation, which can lead to release of uh, more organs, I mean more eggs, and as a result, someone can end up with multiple pregnancies like triplets, quadruplets. All those can be a result of, sometimes can be a result of this hyperstimulation. Then multiple pregnancies, I've already mentioned about this. Then risk of congenital abnormalities can also happen. The second kind of treatment is human menopausal gonadotrophin, HMG, and human chorionic gonadotrophin, HCG. Here the indication is ovulation failure after clomid. In case the mother has used the clomid, we need to monitor hormone levels. Then the next type of treatment is bromocriptine. The indication is hyperprolactinemia in case the mother is suffering from hyperprolactinemia, and this can be identified by presence of milk in the mother's breast, though also the prolactin level can be tested in the body. Then the dosage, we start with 2.5 milligrams nightly for 4 weeks. Stop if ovulation occurs. Then the fourth kind of treatment is we can use agents like steroids. We have methazone, which can be 0.5 milligrams nightly. Then prednisolone, which can be 0.75 milligrams. We can also use estrogen preparations to support ovulation induction. Keynotes: psychotherapy. Address emotional causes, e.g., stress and tension. Common cause of amenorrhea in most cases is pregnancy. So pregnancy remains the most frequent cause of secondary amenorrhea. Oligomenorrhea. Oligomenorrhea refers to infrequent menstruation, often seen months before menopause or due to emotional upset. So the kind of menstruation is infrequent, is not regular as it should be. So the treatment conduct thorough investigations to exclude serious conditions like neoplasms. Reassure if caused by emotional factors. So if the factors, if the major cause of this is known to be emotional, then the mother needs to be reassured so that she can stop overthinking. And dysmenorrhea. Dysmenorrhea refers to painful menstruation due to increased prostaglandins causing uterine spasms and ischemia. Types of dysmenorrhea include primary dysmenorrhea. Primary dysmenorrhea starts after puberty with pain lasting a few hours to 2 days. Then pain is cramp-like in the pelvic and the lower back region, radiating to the legs, often accompanied by nausea, vomiting, and fainting. So that is primary. Then secondary, the dysmenorrhea. This one is normally caused by underlying conditions, for example, pelvic tumors. So let us look at causes and theories of dysmenorrhea. The first one is increased prostaglandins from disintegrating endometrium. So they assume that due to increased prostaglandins that result from the breaking down of the endometrium, this is what causes the pain. Then others state that uterine ischemia from strong contractions cause the pain. Others also state that psychological factors accentuating the symptom. And others will state that cervical stenosis may contribute, especially before childbirth. So management, how should it be managed? History and examination. Record severity and the duration of pain. Exclude pelvic tumors through examination. Then health education, importance of exercise and maintaining normal activities. Reassurance, symptoms often decrease with age. So in most cases, it's very, very common in young girls. And as the woman grows, she starts giving birth, then this kind of pain can decrease. Medical treatment, analgesics such as aspirin or paracetamol can be taken 2 tablets, TDS. Mefenamic acid, 500 milligrams, can be taken TDS to inhibit prostaglandin action. Then flufenamic acid and indomethacin, caution for asthma patients. If the person is having asthma, then the person should not use this. So we can also use ovulation inhibitors. These include combined contraceptive pills, for example, micronuvula, then high progesterone and estrogen pills for 4 to 6 months can be used. Beta receptor stimulators can also be used. For example, rotridine, salbutamol, Tabutaline can be used, and it is assumed that they can relax the uterus and minimize the contractions. Then these are effective, but may cause side effects. So when we use them, we should know that they are likely to cause side effects. Surgical intervention. Pre-sacral neurectomy as a last resort can be done, but this one is very rare unless all those other kind of treatments have failed. Membranous dysmenorrhea. This is a rare condition where the endometrium is expelled in large pieces or as a complete cast. The cause is unknown, and the treatment can be progesterone only medications that can help. Secondary or congestive dysmenorrhea. This is a painful menstruation caused by acquired pelvic pathology after years of painless cycles. So the mother can start her can go into her menopause and stay for several months or several years. Then out of a sudden she starts feeling painful menstruation during her periods. So this is what is termed as secondary or congestive dysmenorrhea. The symptoms include dull, aching, lower abdominal pain starting 3 to 10 days before menstruation. Pain can be relieved or persist after menstrual flow starts. These can worsen with exercise. So what are the key notes that we should have here? Onset after the age of 30 requires investigation for reproductive pathology. So in most cases, if this happens after the age of 30, there must be something pathological that is causing it. Otherwise, at that age, then we don't expect it to happen. Like I stated before, this is mainly happening in the young girls. Causes: chronic PID, most common linked to infertility. Endometriosis, uterine fibroids, acute uterine retroversion, then salpingitis. So these are the major causes of this secondary dysmenorrhea, especially if the woman is already at the age of 30 and above. So management, history and diagnosis should be done to identify the cause. Then address underlying condition, for example, PID treatment, laparoscopy for endometriosis. Premenstrual tension syndrome. So premenstrual tension syndrome, which can be termed as PMS, is a predictable set of symptoms occurring 12 days before menstruation. The symptoms include physical, water retention, bloating, breast tenderness, abdominal stroke back pain, headache. Then autonomic can include dizziness, fainting, nausea, vomiting, sweating, then hot flashes. Then mood, irritability, depression, crying spells, and tension. Then congenitive symptoms can include forgetfulness, poor concentration, and insomnia. So these are mainly the symptoms of PMS. Common complaints include abdominal bloating, breast tenderness, and irritability. Etiology: fluid retention due to steroid hormone deficiency, endocrine Time changes, especially progesterone deficiency, like the state. Then NSAIDs, stress management, exercise, psychotherapy. Diet adjustments, including low sugar, caffeine, salt, high protein, complex carbs, and vitamins. Let's look at dysfunctional uterine bleeding. So, dysfunctional uterine bleeding refers to abnormal kind of bleeding due to hormonal imbalance, and these include estrogen secretion. Diagnosis can be made after excluding other uterine bleeding causes. For example, infections, trauma, uterine fibroids or polyps, ruptured ectopic pregnancy, genital cancers, hormonal treatments. So these are the things that need to be excluded before we can confirm that it is a dysfunctional uterine bleeding. So what we need to note is that patient education is crucial to alleviate anxiety about symptoms being mistaken for dysfunctional uterine bleeding. We shall look at dysfunctional uterine bleeding into details in our next lecture. Thank you for being part of this lecture.